All right, and we're going to start the webinar now. Hello, folks. Thank you so much for joining us here today. We're going to get started. My name is Kristen Urquiza. I'm one of the co-founders of Marked by COVID, and we are really excited for this teach-in and webinar today. Marked by COVID, for folks who might be new to the organization, is the COVID justice movement that is founded and led by people who've been severely harmed by the pandemic. Folks living with long COVID, people who have lost a loved one, others that are in financial free fall as a result of our policies and choices over the last couple of years. We're so grateful for the leadership of all the folks on the call, but in particular, Deshira Wallace. She's a public health advisor for the Marked by COVID team, and will be leading us through this discussion today. So I will pass it over to Deshira, and thank you all so much for being here today. And without further ado, Deshira.
Hello, everyone. Good morning or good afternoon, depending on the time zone. I'm Deshira Wallace, and I will be your moderator for today. And thank you, Christine and Kristen, as co-founders of Marked by COVID, for really hosting this space. So without further ado, I want to introduce our two honored speakers. The first is Yasmin Barrios. Dr. Yasmin Barrios is an epidemiologist at the Yakima Health District in Yakima County in Washington State, actually her home county, her hometown. And her current focus in the Yakima Health District is COVID-19 surveillance and managing of the district's health data. She's a 2021 graduate in the Department of Epidemiology at the Gilling School of Global Public Health at the University of North Carolina, where I'm actually also at the University of North Carolina at Chapel Hill. And her substantive area of research was reproductive epidemiology, with a focus on maternal mental health, specifically depression and anxiety. She earned her Master's of Public Health at the University of Washington in 2008, with a focus on community-oriented public health practice. And prior to starting her doctoral program, her role was as a project manager in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health, and oversaw 2 large pregnancy cohort studies in Latin America. Our second honored guest is Anna Sutton, who is the Director of Nursing for the Public Health Division at the County of Santa Cruz Health Services Agency. And so she serves as part of the health administration, providing division leadership, oversight, and strategy, reporting up to the public health director and public health officer. She began her public health career as a nurse / care manager in the adolescent family life programs and home visiting program for pregnant and parenting teens and families. In 2005, she had the opportunity to help expand a home visiting program for teens to include behavioral health and clinical work via the Federal Adolescent Family Health Program grant. As a result of that experience, Anna is an advocate for partnerships between behavioral and physical health service providers. And over the last 2 decades, Anna's expertise has been in maternal, child, and adolescent health, with a particular focus on maternal mental health and maternal suicide. So we actually have a very nice background for both of them. And so in recent years, Anna has come back to her roots in microbiology and has been responsible for overseeing communicable disease units in Yolo and Santa Cruz counties. This experience prepared her well to be at the front lines of the COVID-19 pandemic response, where she leads both the disease control and strategy for vaccines. So it's a wealth of knowledge here. I'm very excited to have this conversation. And the reason we wanted to have this conversation was because there's a lot going on when we think about public health, and public health works across so many levels. And the local health departments are so integral to the work that we do. But I always feel like people don't know what the local health department is and what they do. So I wanted to ask our speakers, could you briefly describe the role of the local health department within communities?
Sure, I'll take a quick attempt at that. So I wanted to share a little bit of history of the Yakima Health District. So We are actually one of the first county public health departments. So like in the 1900s, from 1901 to 1910, the population grew from about 13,000 people to 41,000 people. And that's when sanitation, sewage, all of that was a big public health concern. So there was a huge typhoid outbreak, and a local epidemiologist, obviously very much in the similar way that John Snow was looking at the cholera outbreak in London. He was like, hey guys, we can fix this with sanitation and all these different improvements, prevention, education. And so based on his report and his efforts, it spurred the foundation and the establishment of the health district here in Yakima County in 1911. And it was one of the first ones, even though there were some districts, some counties that had local health jurisdictions. This is one of the very first ones that really established it and organized it in the way that most of our county health districts are now. So it's kind of a little bragging point that we have in this county. But yeah, aside from that little bit of history, we basically are charged with delivering mandated services from the State Department of Health, and most of those include, water, sanitation, communicable diseases, monitoring and surveillance, and preventative services. So those are like the three big ones.
So I'll jump in here and just like really similar to Yasmin's description about what local health departments do. I always talk about public health as both a concept of something that we do based on state. We take our directives also from state and county and regional directives here in Santa Cruz County, which is the local health jurisdiction. But we also talk about public health as something that many other divisions do within our county government. So in my agency, we call it an integrated health services agency. We actually have our own clinics system, just outpatient. We also have behavioral health. We have environmental health. We have the public health division, and then we have our administration team. And that, to give you a little bit of perspective, we're considered a medium-sized county with a little over 270,000 community residents. Predominantly, our population is predominantly Latinx and Caucasian. There's a small smattering right now of our AANHPI, or Asian American, Native Hawaiian, and Pacific Islander population, as well as our Black American community members. Not super diverse in terms of that in Santa Cruz. We are right along the coastline here in pretty much north central California. Some very, very conservative parts of the county. We are geographically very, very diverse. We have a lot of microclimates. It makes public health very challenging because you literally go from desert to what I call the fairy forests of Aptos within 15, 20 minutes. So we, in public health locally, we have our day-to-day mandates that we do, just like what Yasmin said, and you can read about in California statute and health and safety law. And I think the most relevant to those who are in the audience now is that when there is a disaster or an emerging threat, we are usually the first to mobilize. And public health here in Santa Cruz has played the role of chief health strategist, pulling together the partners for everything in the last 3 years, from a major fire in the mountains to debris flow, and then of course, COVID-19, and now monkeypox.
Yeah, our ethnicity, racial makeup is pretty similar. We have a large population of Latinx and involved mostly in agricultural. This is a hugely agricultural area, and the other large race group is white. Again, similar to Santa Cruz. We're very similar, Anna. And so the large agriculture brings a lot of migrant individuals. So we have somewhat of a migratory community that we also are responsible for. And similar to what Anna was mentioning, a lot of the political makeup tends to be represented by the United States current condition of that political divide. Yeah.
Yeah, thank you so much. You all do broad things, and I think it's reflective of how broad public health is. And often when we think about public health at the federal level and depictions that have been going on recently, it's ends up being very medicalized, like it's just MDs mostly speaking about public health, or you may have some epidemiologists, but you don't have the nurses, you don't have the environmental health groups, you don't have the social workers coming in. Like, it's such a broad understanding of what public health actually is, but it's not always done in practice. So it's really great to hear that within local health departments, it's actually done in practice. So it's not always reflected once you get, really at the top of the federal government. And thinking about, and the title of this is really thinking about community and community health. So what are some examples of local health departments and how they protect the public, including the most vulnerable? As you spoke about the compositions of your counties, within those groups, there are also higher levels of vulnerabilities depending on, so for Yasmin, you were working with a lot of agriculture and migrant workers, the amount like pesticide exposure and all those different things. For Anna, you're talking about the microclimates and you're thinking about even climate change, heat changes, and then you have wildfires. And so kind of how does your work kind of reflect on protecting within local communities as well?
I'll talk about, I'll use monkeypox as a example because it's trending and it's kind of exciting to think about something other than COVID. Although my fear is that in talking about monkeypox so much now, we're going to have forgotten about all the lessons learned that we had from COVID-19. And here at the local health department, COVID for 3 years made our team tired, exhausted, and burned out. Yes. However, it made us much more nimble and better at responding to monkeypox and addressing some of those equity issues for our vulnerable populations. And so when I talked about the local public health departments being like a strategist, when there is a threat or a concern, or we are taking on a campaign for prevention and doing some advanced planning, the role of public health always will be, at least here in Santa Cruz, our core value is that we function from an equity lens, which means that we are looking at data to tell us, in my mind, there's usually 3 questions I ask, which is who is least likely to know or access, who is going to be most affected and don't know it, and who is really going to have the most difficulty in actually getting services and treatments for whatever threat they need. And we always ask ourselves from that equity framework who we must target and focus resources on for public health resources. Then the second question we always ask is who else needs to be at the table in the community? Who are our partners that are already serving these vulnerable populations, and who are also the partners that are serving everybody else? So for example, like with monkeypox, vaccine and treatment TPOXX is really, really difficult to get still. Local health departments here in California are still having to gatekeep and order through what we call the MOHAWK, the medical health officer, a coordinator. It's part of our emergency medical services organization here in California. MOHAWKs exist in every single county, and they are the ones that actually work up to the state level to bring in therapeutics and medical supplies for the local hospitals and skilled nursing facilities by statute. So when monkeypox hit, these vaccines and these treatments are all gatekept by us. We are trying to also gather data and intel to figure out, who's most affected. We have community education and outreach. And then we also need to then get these vaccines and treatments out to the healthcare systems who are already, should be, not very well right now, poised to actually give vaccine and treatment. So those are really, really critical key functions for a local health department in serving the community. So I'm going to pause there and let Yasmin say a little bit.
Thank you, Anna. So for us, we also obviously take an equity lens. We do have, significant numbers of migrant populations, as I mentioned, and a large proportion of homeless individuals, and also on a lot of markers, metrics such as chronic disease, infectious disease such as STIs and drug use, our numbers are quite high compared to the state. And so we tend to have a lot of subpopulations that really we consider vulnerable and need services. So historically, the Yakima Health District has developed services for these populations that tend to be longstanding. For example, our needle exchange program has been in existence for about 20 years. And that's something that for the length of time that it's been in action, it's become a community resource and also a place that consistently communicates and is a place where individuals not only get the needle exchange service, but other public health items such as, condoms, wound care kits, all of these other things that essentially can be their one access point to some healthcare. So that's just an example. But during COVID, having to stay pretty nimble, we prioritized maintaining those programs in action. So while we turned completely our focus, as everyone did, to COVID, there were still some sort of bare bones activities that we didn't let slide because they have been so entrenched in the services that we provided. So so equity, but also the continuity of that engagement within the community has been really important for the health district. And I'm fairly new. I'm only there a year and 4 months now. So a lot of this is what I've learned from conversations and from what I've heard, but also the relationship building seems very strong with the other organizations that carry out services and that partner with the services that the health district provides. So where we saw a lot of that, a lot of the benefits of having established those long-term connections when COVID started to be the main issue. And through that, we really worked hard to maintain those services that already existed while directing a lot of the resources and most of the attention to COVID. We supported organizations and we received a lot of support. So Washington State is pretty good in terms of the State Department of Health in being very good at guiding local health jurisdictions. I may be losing the point of the question to answer it, but I think that collaborative experience, which I've noticed and have experienced since joining the team, is really what I see as part of the health district's sort of function and the way that they strive to do the work. So it's always conversating with partners and looking towards the leadership from the State Department of Health as well.
This is really good. And it was interesting to hear how with COVID and the COVID response, you both felt like your local health departments were able to, and I think I'm going to use the word be resilient in terms of some ways keeping existing programs in place. And that's one of the key areas of emergency response. Can you keep your baseline the same or similar to make sure that you're not causing inequities in other places, which we have seen with reductions in people being able to get screened, or we saw this with HIV testing actually across multiple countries. People, they were afraid to go to healthcare centers, or healthcare centers would just, cancel appointments. And now we saw just such a delay. So that kind of piece, but also just being able to respond to ongoing threats, which we're now seeing with monkeypox. But I'm trying to think of, so COVID actually did change the roles of how health departments are functioning. And I kind of wanted to go a little bit more into the positives, which like this nimbleness. But are there other ways that the COVID response changed how you all function as a health department?
I'll start on this one. So I don't know if this is common practice across the nation, but with FEMA, those federal emergency management dollars that came in, something that's always required of any FEMA funded response is what we call the after action report. And it's a formal process that's supposed to be done within 90 days, 90 days to 6 months, immediately following the closure of the event. Now, with COVID, we couldn't figure out when the end of the event was, because each surge of COVID was its own distinct event, in my opinion. And there was so many learnings from each time we surged, but we made an attempt. We picked a finite time period that included what we call the landmark sort of changes in COVID, which is like the advent of contact tracing. And then there was the advent of testing. And then there was the advent of vaccines. And now we have this advent of basically the major sectors of the communities, because we are talking about COVID being endemic, major community sectors really owning the ability to respond to COVID without just picking up the phone and calling the local health department. So do you all have your own COVID response plans? Do you all know how to educate your workers around isolation if folks get COVID? And do you know labor laws and Cal OSHA and all that other stuff? So it has really shifted over the last 3 years. Repeat your question one more time. Sorry, I'm thinking about like what I want to say and then I forget the question.
Oh, no. The question is basically, how has the local health department shifted with COVID?
So one thing that was a constant, and there was actually a grand jury investigation right around the first year of the Santa Cruz response. And it's always a good thing when people, raise a quality question. And that finding of the investigation was that the public and the community really didn't understand what public health did. Exactly the point of this webinar and this teach-in. So we really took that to heart. And from there, we invested in a public relations and social media coordinating company, consultant, Volair here in California. That's who is doing a lot of our postings and development work, in addition to really beefing up our public information officer and communications team. That's actually a full-time thing for us here in Santa Cruz, having a PIO and comms team that's made up of a bunch of senior health educators and health educators. And so that was the first year. Now in this second and third year of COVID, what we're really finding is there's even more misunderstanding of the role of the health department because they're so used to us now being the ones running the mass vax clinics, setting up the testing sites, being the first ones to call. And we're saying community and businesses and, large sectors calling us to say, what do we do? And this last year, we've really been trying to message and communicate and really give back that power and give back that knowledge to the community and to the businesses to be able to handle COVID on your own, just as you would flu or chickenpox or any other major disease that might take out a few of your staff, and make them sick. And we have found that communication, again, we've had to pivot. And this time around in our after action report, even a bigger investment in the community public health interface, through things like more town halls, a lot more social media, and then bringing the voice of folks like all of you in Marked by COVID, promotoras, electeds. We need more platforms where the community and the electeds are actually co-developing strategy with us, because the 150 of us sitting in the health department making these decisions, while it might be good, when we roll stuff out, unless the community is co-owning it, it is not going to work. So.
I'd have to piggyback on that with the fact that really the communication is something that has shifted and probably evolved during COVID. And a statement as Yasmin Barrios, not an employee of the Yakima Health District, but I was a student in EPI when the pandemic started, and I was studying risk. I was studying all these EPI terms that the population in general thought they could understand with just a quick Google search. And as a student, I was like, how do you want to become epidemiologist in a day? By Googling. I really thought that, and it's a lot of other people thought this, but I thought that the public health science communication was really the part where we failed as a scientific community. So with that, that's a Yasmin statement. Our health district invested a lot in new positions because funding was available. All of a sudden, the influx of funding made it possible. Our health district is about a 45 person team, and we serve about 250,000 individuals. So it's small compared to Anna, I think your team, but all of a sudden there was funding for additional public health nurses, the contact tracing teams that were supported through the state DOH, and there was funding to hire an epidemiologist. My county hadn't worked with an epidemiologist from my understanding, even though I've never been able to confirm, in like a decade or so. They've outsourced to universities and contracted out, but hadn't had an epidemiologist in-house. So our communication really turned to social media, turning out reports. Our community really wanted those numbers, really wanted to understand that. So a difference from the people who would Google and become certified armchair epidemiologists, there was a clear interest and a clear like hunger for data and understanding, because they want to be involved in that decision making. Like Anna mentioned, there needs to be more opportunities for them and our leadership to really engage in those conversations. And so just putting out weekly reports, daily reports, having the ability for community members to reach out and request, we would have pharmacists being like, well, all these people are coming in for like removing all our stockpiles of cough medicine. Does that mean we have a way of like, just the conversations that started, it was like, oh, they want data. They want to understand it. How can we make it, digestible for them? And that's something that thoroughly improved, in my opinion, from the start of COVID to where we are now. And it's the opportunity of having an epidemiologist allowed, my role to sort of become the person that our media team would come to and be like, okay, if you're going to have these media questions, this is what they're asking and this is why they're asking it, to know what the rest of the research coming out is saying, and what sort of like the pulse points of some critiques are about the current understanding of COVID. So all of that changed, and it was because they were allowed to have more funding to search for people that were going to support the work of public health. And one more item I wanted to mention that you touched on, Anna, is this after action report and the relationship with FEMA. So Yakima County was selected as one of the, I think, 70 some mass vaccination sites. And we'd never really had worked that closely with FEMA in such a quick response. My first day of work actually was when the FEMA site got up and running. So I showed up to the office and everybody was gone. I was like, I can't get into the office. And then my boss calls me and she's like, we're actually at, the state fairgrounds. So if you can drive over here, this is where we work now. And so, the whole operation was moved to just begin collaborating with FEMA, and the ability for a small health district to scale up and be responsive to what FEMA kind of the way that they operate was really impressive. And I was impressed from that, never having been on a site like that, never having worked with a local health jurisdiction, but it created relationships, I think, with the federal government. Hopefully will show them that they can entrust small little outfits to handle these like large operations and do it so equitably. We also implemented mobile vaccination units. So while people were still considering how to get vaccines to individuals, we didn't hesitate and we started doing mobile vaccination sites almost in tandem with the FEMA vaccination site. So that was something that we had always kind of wanted to, or would always aspire to as local health jurisdictions, but just to kind of force you to move ahead with what you knew was a solution to a problem, which was access to vaccinations, excuse me.
Wonderful. So we're getting a lot of questions. So people are very much interested. And I didn't have that many questions set up beforehand because I was aware that people would ask. But I did have one question that's kind of linked to one by a participant about support. So how do communities, or what are ways that communities can support their local health departments? It can be contentious certain times depending on who the audience is. And we want to make sure, like, one, that we can support our local health departments, local health districts, and specifically the people who work there, because you're all human. So what are some ways that we can support local health departments?
For me, it comes down to, I don't know if this is understanding, really grappling with as a community member what prevention is. During COVID, we saw what prevention does. The rates of STIs, the lack of access to doctor's visits that led to late diagnoses of potentially cancer, all these other things that sort of had to go by the wayside. All of those things happened because public health had to focus mostly and solely on COVID. So we got to see the fallout of a vacuum of preventative services. And I think that the community understanding that would go really far to being open to receiving those preventative service messages, to really understanding that just because you don't really see prevention doesn't mean it's not there. So I don't know how that gets into an action, but that's my primary way.
I'm going to go really like narrow and focused because it's something we're grappling with in Santa Cruz County right now. And I am doing this on work time, to be totally transparent. So I do represent the values and mission of Santa Cruz County Public Health Division, but we are very, very interested as a health department to enable and empower our healthcare providers to actually meet the people where they need to be right now, across what Yasmin said too, preventative services, immunizations, and all that. So specifically here, coming out of COVID, starting school again, aging population, and now the threat of monkeypox, we really could use community members to actually call their insurance companies, call their healthcare system administrators, not their providers. Their doctors all get it. They all want to see their patients, and demand the quality services that you pay insurance premiums for. I think people don't understand that their money, when you have insurance, and even if you're on, we call it Medi-Cal here in California, Medicaid in other states, even when you are on publicly funded insurance, there is a premium being paid on your behalf to an insurance company who's supposed to manage a network of healthcare providers to give you good healthcare, which includes a lot of preventative services now, thanks to the ACA that was passed in 2013 or 2011. And so it is the consumer voice. Be a consumer voice, be your own patient advocate, and say, I need this. This is good preventative health. This is also good intervention. And it's not acceptable, and say it diplomatically, and, of course, be professional and everything. But really demand those services that you're paying for. Healthcare should be a right and not a privilege. And I'm seeing that actually those individuals who are on our Medi-Cal, our public insurance programs, are actually getting better service than those who have private insurance, because there's actually an advocate for those on Medi-Cal here in California that are really demanding better for our vulnerable populations. And I think I take this away from my maternal mental health work, which, Yasmin, you and I need to talk offline about that. But I remember also trying to get maternal mental health services and children's behavioral health services for privately insured kids and moms. way harder than the public system, I think, because there's less transparency. So we really need all of you as the recipients, the beneficiary of health benefits, to actually tell the administration it's not working. I should not have to wait 3 weeks to get a vaccine appointment for my 5-year-old. You knew vaccine was coming. Why are you not preparing for it? How can I be assistance to you, administration of this local clinic, to make sure that, for fall flu clinics, that we don't have to wait too late to get vaccine, things like that. Thanks.
Yeah, that's really helpful. I'm always curious about, we know things are coming, but the preparedness and the flow of things, it's just always a little bit surprising to me about how things work. And for example, we knew monkeypox was happening for a long time, and yet we're hearing stockpiles are left in different countries. I was like, it could have been shifted around in a way that made more sense and was equitable actually globally to make it easier to control. Yasmin, did you have another point?
No, I just think I really wanted to highlight and thank Anna for your concrete example. I think that, how long have you been in your role?
In this current role, almost 2 years, and in doing this work, about 22 years now.
You can tell the difference between a brand new person in this role and seasoned. I think it's I really appreciate that. I hope to get to that level.
You're already thinking about it. I don't think necessarily it's years of experience. I think it's just you're seeing it through, and Yasmin and I have really different roles and training. So Yasmin, someone like Yasmin would actually sit in the Santa Cruz Population Health Unit, which has a bunch of EPIs and IT business developers and analysts. And they are the ones looking at the data, telling the story and the trends to help us inform strategy, policy, and procedure. So it's a really different place where I sit. I'm much more operational, which is probably why I can grasp the details a little bit more, is because that's my job. Right. And so I would be leaning on someone like Yasmin in a local health department to say, what are the trends? It's because there's lower ER visits, lower IZ rates. So she and I would actually be working very much in tandem as a partner to tell the story and then actually write the strategy for the local health department.
That's great. We have a lot of questions, so I apologize to anyone in the audience if I do not make it to your question. But we have one question that was what Anna mentioned about trying to figure out who needs to be at the table. So what are your suggestions for how community can be connected to their local health departments so that they can be at the table? And you mentioned, advocating to health administrators and talk to insurance, but when you have these plans in place, how do they know how to engage?
So a couple of ideas, local level and then state level. At the local level, many health departments will have advisory boards and committees, and you have them at the city level. So your local city council will have a bunch of advisory boards on a variety of health topics. So there might be a health inequities, social services, aging. Get involved with those councils. That's how your voice can begin to be elevated in a formal setting to change policy or to raise data requests. If you're at the county level here in California, and I'm sure there's parallels in other counties, in other states, we also have advisory councils, advisory boards to the board of supervisors. So this is like your basic civics lesson. Forgive me for this, but in a county in California, we have boards of supervisors. They're essentially the bosses of everybody that's in public sector. These are elected positions. And oftentimes each of these board of supervisors has a district within the county. And they also each have maybe their interest, right? Their special interest, like one's in aging, one's in maternal child, one is in community services. They will chair these advisory boards, which is like a citizens committee, a citizen's voice. And so they will ask for the county, the community members of the county to volunteer to serve on these advisory boards. You usually apply, you get selected, and then you sit as a selected member of these. And these are public meetings. They are aired, they're sanctioned by the government. And a lot of times, based on the topic, local health departments and other county government offices may pull on the advisory committee and say, hey, we're about to pass a piece of policy, or we're going to get this funding. What do you think? And in the previous county that I worked in, which is Yolo, which is right below Sacramento and near San Francisco, similar size, similar makeup to Santa Cruz, just not on the coast. We had a maternal child adolescent health advisory board, which I chaired, and that gave, we wrote a policy platform every year and presented it to a board of supervisor. And we had representatives from different medical disciplines, but we also always required somebody that came from a community-based organization and a parent of a child who is receiving some sort of federal or state benefit. So that could just simply be like a 504 plan or an special ed plan. But we wanted to have the voice of the child. And we also wanted to have a community member who was just generally concerned about the welfare of moms, babies, children, and dads. So these advisory boards, maternal child advisory board, health councils, which look at, generalized health issues, these are all your entry points into public run, Browns acted types of platforms to raise your voice up, and health departments will tap them.
Yeah, similarly, our Board of Health is made up of county commissioners, 3 county commissioners, and then town, the mayor and a city council member, and then community representatives, which are also selected. Some of them are politically appointed, and some are elected, and then some are community members that are selected. So essentially, that is similarly where you can go to become more familiar with the conversations. That's where we get together, and at the Board of Health meetings, the health district and the Board of Health communicate about our activities and how they would like us to proceed or how they would guide us. And then it's open to the public. It's also an opportunity to voice your thoughts through public comment. So yeah, engaging, running for office, running for local office, if that suits you. I think it's been made very clear that local elections matter.
All right, everyone, local elections matter. Figure out what's going on in your, that's where you have the most power. Like, we do focus a lot on federal government and what's going on federally, but things trickle down in different ways by the time they get to you, based on the county, based on the city or town. And so really think about who is in charge. Who are they representing the interests of specific types of people, specific groups of people, and really think about, do these boards understand the science? Can they speak to the science? Can they explain the science to the community? Because if they can't, then this is where things get really an additional place where we get stuck a little bit. So there's a lot of places where you get stuck in public health, but that could be one. We've had several questions that relate to basically the stability of the health department workforce, where it's like, burnout, we already mentioned the word tired and things like that. Also, like how it can be difficult sometimes engaging with different groups because it could be contentious, but also thinking about money. So you all mentioned, FEMA dollars, and you have some monies that came in for emergency response. So there's like the emotional piece of like, how do you keep the department going? But there's also a financial component of, if you have one-time dollars and you could hire all these people, is there a shrinkage that will then happen after a couple of years? And how do we manage that? So sorry for 2 questions in one.
So the 2-part question is the emotional management and then the fiscal management, or the preparation of everything. I can start this one because it's literally what I will be going into at 1:00 today. And that's what we talk about all the time because we're getting ready for budget season. So I think first off, if there could be an ask for people on this call, really do get involved and understand, at least if that is the battle cry, for this community to do advocacy, is to really truly understand what public health can and cannot do, and understand that for almost over a decade in California, public health has been underfunded year after year after year. So what you saw from public health at the beginning of COVID-19 is not what any of us went to school or got training to hopefully do. We knew going into a public health, especially local public health, that we were always going to have to, what my professors taught me was do the most with the least. And that's why we focus on population. So, but in terms of workforce, which is actually a big part of what I do, workforce development, workforce retention, I don't have the answers. Honestly, it is the hardest thing that faces me every morning that I wake up. I find myself texting my staff a lot, which helps, and having to do a lot of one-on-ones to really assess where they are. Every single time something comes up that's new, that is an ask of my team, I'm assessing for, did that trigger you? Are you having a trauma response? I'll be really honest, that's where we are in Santa Cruz. I think I speak on behalf of many health departments in California when I say that every time there's something new, we just feel like we just can't catch our breath. And to have folks not understand what local health departments do and have these expectations that now that there's monkeypox, we're the ones having to set up mass vax, and then having anger directed towards us because we're not doing it. It's really hard. And I think the word moral injury has become a regular word used for us. We want people to understand what we can and cannot do because sometimes our hands are tied. So that leads to the fiscal management, which is I'm scared, honestly, personally and professionally, of what our communities are going to think of health departments because they are watching and reading the news about all this money that has come into us. And yes, we got a ton of money, but it comes with a lot of rules of what we can spend and not spend. And then there's a local county rules around hiring, which is not fast because we're capped with civil service job classifications, which cap salaries. We can't give bonuses. So for things like nurses and EPIs, where we are just not competitive, but we desperately need them to rebuild our public health department to do what we have to do in a transformed state, which is to strategize and organize the community as a whole to respond to the next threat and to prevent it. But I think fiscally, we're looking at a 2-year cliff. Most of our money that's coming into California right now is probably the same for Washington State. Our federal dollars allocated for COVID-19 pandemic response, really focused in on like lab capacity, contact tracing, workforce, but that's all going away in 2 years. So it's really hard for people to sign up for a job when they don't have guaranteed funding in 2 years. So it's really hard to hire, and it's really hard to build infrastructure when you have no idea how you're actually going to finance it long term. It's really hard to sell it to your administration.
I don't think I can add much to that other than the lived experience of this health district only having the funds to hire an epidemiologist, and my willingness to be in this county solely because this is where I grew up. And it was like the perfect storm of, well, I've graduated, I don't know what to do next. There's a huge need in my backyard for my exact education like choice of profession, so why not? But I think it's really hard to attract people to counties who you know are going to have limited resources, either because historically public health has been underfunded or because it's uncertain the future of the funding. I think from what I see from our leadership, and I'm not in the rooms for those discussions, so I can't speak to what they are or not doing. But what it seems like is that it does take solid leadership and individuals such as Anna that really look out for their employees. I feel in my current position, like I mentioned, I've only been there a year and a half, so missed the beginning of it that really put the health districts to the test in terms of their ability to be flexible, their ability to switch responsibilities immediately. Some people in our health district were hired, and then a week later they were hired for like the disabilities program, and then a week later they were having to do contact tracing. So they had to like you said, be prepared to take on whatever role is in need. And what I see as a success is the leadership. They took the time to really not insulate them from the communities the members who had really awful things to direct at them. But I felt very protected through that leadership bubble, so that I could do my work and not have to worry about getting emails that were nasty because they were directed to the people in charge. And that was just, an example of what I saw happening. And I don't know how often or how capable or how much bandwidth other leadership in other health districts had to do that, but I think that helped in our health district. And just constant checking in, like Anna mentioned, has happened. I feel very much like I didn't need that checking in because I wasn't part of the really stressful first year response, but it seems to have been occurring, and that seems to have been really important. And that's just at an organization level. At a community level, I think it's just been really interesting to watch health being politicized in a way that it never has. Even though health technically always has been a political issue, it's never been politicized to the extremes. And I think that's really hard to recover from. I think that a lot of the issues that we'll face with monkeypox are going to be carried over thoughts, exhaustion, misunderstandings, and it's concerning to me that will continue on, because people are going to be more aware of what a public health emergency is. They're going to be more interested in reading. They're going to be more interested in getting their hands on information, and we can't always be sure that the sources of information that they're accessing are going to be reliable, valid, or honest.
Yeah, there's a lot happening, and there's always so many more questions in terms of what can health departments do now. But health departments have been, as we've heard, changing, moving as you saw that communication wasn't getting to your communities in the way it needed to. And you mentioned, you have a public information officer, like you switch things up and how they need to be done, but it had to change at every single touch point within the COVID response. And we're still seeing that now too. And what I'm seeing, as we're going to end kind of with monkeypox, it's very similar. It's an infectious disease, but we're trying to use like a health equity lens, but not everyone knows how to explain that well. So it ends up becoming poor communication to the point where now it's kind of like, well, it's among, men who have sex with men and gay men. That's actually not, we know that that's not how things are transmitted. And the poor communication has now added to a lack of actual action and prevention and protections in place. So now we're having an outbreak when the last outbreak was only 46 people, in the early 2000s. Like, why do we have thousands of people now with monkeypox? So it's not like these are not new issues. These are things that happen again and again, and it feels like the lessons learned. I don't want to say I'm going to ever put them on the local health departments, because it's a consistent thing across all aspects of public health. How in academics we talk about things, how we talk about them in the federal governments, across different countries, local health departments, cities, in medicine, and in clinical spaces too. So it's a consistent issue. How do we go about this with a health equity lens? You all have explained how you go about it yourselves. And I'm saying all this to make sure we know that we're finishing up, because we're ending in 3 minutes. Just really making sure that we understand. And the goal of this was to explain and give a little bit of insight into what a local health department does and what are some things that we can do to support, which we've heard are really looking at your local governments, what's going on, if there's a town hall, attend. And also, I would say personally, check your community members. If they're saying things that are very much terrible, very ad hominem personal attacks to members of local health departments, and you're at a local meeting, I think it's okay to be like, no, that's not how we do things. Like, you could be frustrated, but that's not that's not how you express your frustration, right? We can talk about this as a collaborative together. So as community members, I think it's okay to, you know, call out your other community members to make sure that we understand that we're actually all in this together. And so as we wrap up, I want to definitely thank Marked by COVID for sponsoring this. And also, if you get an email, thank you so much. We're going to email everyone who's attended and people who couldn't attend with a recording as well. And I think Kristen put in the chat if you would like to donate to Marked by COVID and its efforts. It's very much a small organization that's trying to do the advocacy that Anna and Yasmin have been talking about today across the country for those who've been impacted by COVID-19. And we're going to see by other conditions that also probably have an underlying effect by those who actually also were impacted by COVID-19. We're going to have 2 more teach-ins. One's going to be on workplace in September and on schools. So we are so thankful again for Anna and Yasmin for being here. Thank you everyone for your questions. If I did not get to them, I'm very sorry. But thank you so much again. And I hope everyone has and yes, we're going to try to keep any questions and see if there's ways that we can address these and maybe other spaces too. So please come back to any of our future teach-ins as well. Thank you all so much for being here. And oh, someone asked, Anna and Yasmin, do you have any contact information if you have any questions?
Yeah, I think all of my information is public. So my email, I'm on LinkedIn. Feel free to ping me there.
Yeah, I think mine should be, I think they just updated it. Like 2 weeks ago, you couldn't find my information, but I think it should be up there. Otherwise, Deshira and this group, you are free to pass along my contact information.
Okay, thank you. All right, everyone, have a great rest of your day and week.